show you a few approaches, and then we'll show you an augmentation with a specific set, and then we'll show you, in addition to the balloon augmentation, we're going to show you an implant. So first, we're going to do transpedicular approach, similar to what Dr. Charnard was showing you. And this one is about a centimeter up, 2 centimeters out, and this is a similar trajectory, and I will contrast the perpendicular approach to the transpedicular approach. Go down until you hit os, and the targets on this is going to be the 10 o'clock and the 2 o'clock position, so of each pedicle, so left and right respectively. So you go down, tap, tap, and you're going to give this a test and see how hard the bone is. All right, so bone is pretty darn hard. All right.
So, Doug, for the audience, what are you trying to landmark there?
So
in terms of the
we're going to 10 o'clock position of that left pedicle. And as we hammer this in, that's about the right position. I like that quite a bit. The cadaver is pretty hard. So what we're going to do is we'll get, before we violate the medial wall of the pedicle, we're going to go lateral to see if we're in the posterior portion of the vertebral body. And if we are good, if we're not, we'll do some trajectory altering adjustments. And as you see, this is a single beveled needle. So the start positions are 10 o'clock and 2 o'clock on each portion of the left and right pedicles respectively. And we'll see we'll start at the kind of the top of the pedicle body junction, and as we approach, we're beyond the posterior wall of the vertebral body, and we are actually in the vertebral body itself. So if we were to do a transpedicular approach right here, we would pull this back to about within 5 millimeters beyond the posterior wall. We would drill. Let's do this. And as Dr. Schonard mentioned in the drilling, you drill and use it live, and you don't drill all the way up to the anterior portion because of the curve of the vertebral body. You can be outside the vertebral body if you drill up to the very anterior most wall. So we drill like this, and we'll drill to within 3 to 5 millimeters of the anterior wall, perfect position right there. We'll come back around AP, and we'll take a shot of that to double check our trajectory in the AP. And typically the transpedicular approach, we will do this bilaterally. And so we like that. It's right between the pedicle and the spinous process. That's perfect position. You can imagine this with a mirror image on the other side, and you blow your balloons up, deploy the cement, or even a bilateral vertebroplasty, and that would be very appropriate. So instead of doing anything else at this point, I'm going to show you a perpendicular approach. So on a line that goes from ipsilateral superior to contralateral inferior vertebral corner, we will go a vertebral body width out. And so this will put us, you remember my perpendicular approach, this will put us right about a vertebral body width here. So this is our start point. And as you'll see on the back of the cadaver, from the initial incision, it's here, my new incision is here. So the trajectory is just farther out. It's the exact same trajectory as we did on our transpedicular approach, we're just farther out. And what that does, it's farther out and provides exactly the same targeting, 10 o'clock or 2 o'clock. We're going to be at the 10 o'clock position just anterior to the pedicle. So right here, what really works very well is to take an ipsilateral oblique about 20, once we arrive at our reasonable target position, about 20 degrees ipsilateral toward me to make sure we're anterior to the pedicle. In fact, we are anterior to the pedicle. I'm going to go a little bit even more posterior. So you want to be right there, right there, just above the equator of the pedicle, just anterior to it. So that's a very nice trajectory right there. And that's where just above the equator of the pedicle, just anterior to it. And so that's outside the pedicle at the pedicle body junction. Then after this, we're going to go directly AP. Take a shot, and that is looking pretty good right there. And keep in mind, we want to come down before we transgress the medial wall of the pedicle. We don't make sure we're in the posterior portion of the vertebral body by going lateral.
Does everyone understand why that is? The whole audience, I think that is one of the biggest points in teaching this is that, check your lateral at this point, making sure you're not transgressing.
So that's a very decent approach. So if we adjust this, we send it more toward the center of the vertebral body. The final goal for a perpendicular approach, the ability to get it toward the center of the vertebral body is enhanced. We'll come right back around and take an AP shot. Because the trajectory is farther out, you aim more lateral to medial, and because you're entering at the pedicle body junction, not the back of the pedicle, means that you can put some trajectory changes on that needle. And so we're right here, right at the center of the vertebral body, center anterior portion. So we'll put it right smack in the midline, and that will be just in the mid to anterior portion of the vertebral body. That's the perpendicular approach. So let's take one more final shot lateral. We'll save that one. And this is designed to either do unilateral vertebral augmentation by putting the needle smack in the center of the vertebral body, because your goal for unilateral vertebral augmentation is end-plate to end-plate fill in the center of the vertebral body. The biomechanical data says the best results you get from this, so there you go, mid to anterior portion and on the lateral view and mid portion directly in the AP view, perfect position. So we'll come back around. And the goal is to get end-plate to end-plate fill in the center of the vertebral body to maximize your reduction. If you can do those things, you will accomplish everything you need to accomplish with a unilateral approach. If you need to, if you're too far ipsilateral, if you need to come back with another needle, come back on the other side, if you need to maximize your reduction, if you're not doing the goals and haven't met the goals that I just stated, come back and do it on the other side. So this will be a little bit different approach. I'm going to do the modified inferior end plate extrabedecular approach. So what I will need is 45 degrees towards you. All right, so at an angle the other way. So I'm going to pull towards you. Good. So at an angle like this, at 45 degrees, our start point is right there. And as I mentioned, you want to get above the inferior end plate, anterior to the pedicle, and you'll often want to use a Coke or something to hold it. This cadaver is pretty frozen, so I won't need that. and we want to come down just above the inferior end plate, just anterior to the pedicle, and then that swath of territory right there, that is the open, relatively avascular, aneural spot. So I feel os at that point, and I'm very satisfied with that position. That's exactly the relatively avascular, aneural spot that we have. It's should be completely avascular because any of the major vessels are already in the center of the vertebral body or just anterior to it. So we have about a 45-degree angle, maybe a tad more, and we want to come from that position. After saving that image, we want to take a lateral view because it's, at this point, easier to go lateral. And we'll get our trajectory, take a good look at it, and we'll take an AP shot after this. And so this is a nice trajectory. But I want to come up. I'm going to use the bevel of the needle to angle it slightly superior just because we like style points. Right, Jason?
Yep.
Okay, so I like that mid-anterior portion. And we'll take an AP shot, and we should be roughly in the mid portion of the vertebral body. And so if this looks different to you, it should. This is a very different approach. It's not at or around the superior portion of the pedicle. It's along the inferior portion of the vertebral body. And so if we want to get a little bit more toward the center, we can angle this as much as we want to. And if you look at the camera that's focused on my hands, you can see how much torque you can put on this just to put it right in the center of the vertebral body. You can really rocker arm this over because the vertebral body osseous cortex on here is very thin, and you can change the trajectory of that needle very easily. So can we save that, and let's go lateral.
And it looks like you're using a bevel tip.
Yes,
Tug.
that is my fastball. I really like the single bevel tip. You can have a better puncture of a curvilinear surface like the vertebral body with the multi-bevel, right? And then this one's a tri-bevel. They also have pencil point. The bi-bevel allows you to go one direction or the other, not necessarily very well against the bevel, but the unilateral direction of the bevel allows you to go in a single direction very sharply because the needle steers away from the face of the bevel. And that's center anterior on the lateral and center on the AP view, and that's perfect position. So
Do you maybe want to try and do a cavity creation at this point?
I think what we might do is I'd like to demonstrate a steerable needle, a steerable device. And so somebody that takes a transpedicular approach, it's the most common. You can either go bilateral, or if you have a transpedicular approach and you're trying to get toward the center of the vertebral body and you're not able to do it for cement distribution or balloon inflation, a steerable device is very advantageous to do that. Steerable device makes average people better. So we will do that. So let's come back around and I'll do the typical transpedicular approach. Instead of doing the same approach and drilling out directly, what we'll do this time is we'll do the steerable device made by Define, and we'll get to the contralateral portion of the vertebral body with the typical garden variety transpedicular approach. So I'm going to access the same transpedicular area, and that, as you recall from the previous access, the first access, the bone was quite hard. So we'll see how it goes this time. Should be able to access an existing track. Okay, go down 10 o'clock position of the left pedicle down to the medial portion of the pedicle, and before we violate that medial wall, we are right up against that medial wall with the distal tip of the needle. So before we violate that medial wall, we'll make sure we're in the posterior portion of the vertebral body. And at this point in time with the trajectories, you see the needle here, it's relatively steep, It's not flat like the perpendicular approach, and it's certainly a far cry from the almost horizontal position of the modified inferior end plate extrapedicular approach. And so we're looking pretty good at this point in time. And so what we'd like to do is just remove the stylet, and we will insert the directional needle. This has actuator here, and it goes away from the face of the bevel here, so it accentuates the normal steering capabilities of the needle away from the face of the bevel, so it bends just like you would bend your spinal needle whenever you're approaching a transforaminal or whatever you're trying to do. So we'll put it just inside the cannula, and we'll make a little turn. And it has an external marker as to the direction of this. So this is going medially and slightly inferiorly. And we'll take it and advance it. And I will put some more torque on it to get the curve to actuate more. And that's right in the center of the vertebral body. This is really pretty powerful. Almost a complete curve. And so for this, I'm going to pull it back a little bit. And we will put it out slightly straighter. Nothing wrong with having it right in the center of the vertebral body, but I want to demonstrate this and have the curve actuate a little bit more toward the anterior portion of the vertebral body, because I'd like to get toward the contralateral side and see how we do there. So at this point in time, I think that looks very good. I'd like to take an AP shot to see where we are in the medial-lateral dimension of it. And this angle goes with the coincidence of the bevel, and it goes from ipsilateral to contralateral. And we are going a little bit from top to bottom because our entry point in the vertebral body is toward the superior side. And we see that we're directly midline here. So at this point in time, I want to get it to the contralateral portion. And so we'll go back lateral, and I put a little bit more torque on the actuator to get it to go toward the contralateral side. And this is a very nice, very powerful directional device, because we can really get toward the other side very easily. In fact, I want to take a little bit of the torque off the actuator, because that will definitely get it done. All right. All right. So like that, we're hubbed. So we'll save that image, take it back around AP, and we'll see where we are. My guess is it will be a little bit past midline contralaterally, and this is going to be a relatively medial laterally placed balloon. We will place the balloon across that in the front part of the vertebral body, close to the midline, and we will blow that sucker up. I like that. I like it a lot. We'll take this out. Thank you, Jason. All right. Okay.
My question was in the audience, how many millimeters is the balloon?
The balloon we have here is 10 millimeter balloon. And we have different sizes. Let's go lateral. But this is one that was just delivered, I think. Please. So we see the same trajectory in the AP. We want to put it in the center and anterior portion of the vertebral body. This is, we want to try to make a transpedicular approach, convert this into what similar results that you would get with the perpendicular approach, having toward the center of the vertebral body. And this is actually pretty easy to do. And we get that balloon, very similar placement and we will inflate. So pressure balloons, these can be rated 400 to 500 psi, 400 for this one. And we've got not even 100 yet. Let's see. Let's get every frozen. We'll see. Let's give it a stress test, huh? So
Yeah, what do you want?
we're starting to get balloon inflation. It's up to 200 psi.
No, I'm sorry.
We'll back off to 250 and back down, which means the medullary bone inside the vertebral body is giving way. And as we inflate the balloon, we're up to 300 psi right now. Balloon's starting to come up. And we're up to 400 and it's backing off. Very nice. Like that a lot. Okay, let's take a shot AP and see how we're doing there. So the curved needle approach with the curved balloon, and the curved balloon is even more across midline, and this is just fine. What we'll do is I'll pull it down, and I'll balloon even more proximally, and we'll get a balloon formation
So I'll turn the mic on and ask.
there and there. And whenever you do this, you'll have to hold the balloon so it won't slip forward on you, the so-called watermelon seed type of occurrence whenever this thing blows up, and we'll get more of a inflation in the center of the vertebral body. Keep in mind, you don't have to blow the balloon up on lateral. You can blow the balloon up anteroposteriorly, and that's very nice. And you could bring it back even further if you wanted to. So we've got nice balloon inflation, we've got nice position, then the center of the vertebral body. Let's save that one for posterity's sake. And very nice conversion of a transpedicular approach that typically leaves you, as we saw from the first approach, ipsilateral between the pedicle and the spinous process. This now puts you right in the center of the vertebral body. And so this is a coaxial delivery device. We will put this in. We'll screw it down, and then let's go lateral, please. On the cement injection, you always want to inject in the lateral, and you always want to watch either moldable fluoro spots or live. I would encourage you to set the pulse rate fairly low on your fluoro, and multiple axial spots is what I prefer. I do not like to have live fluoro. It just increases the radiation. Most of you will have a nice tan for radiation anyway, so you want to avoid any additional exposure that you can possibly avoid. So nice cement distribution. This is a hydraulic system with pressure and fluid that transmits to a cement cartridge, and the cartridge injects through a coaxial injection device, and it's perfect consistency. Nice work, Jason.
Got it. Yeah, thanks.
And we have a very nice distribution. So what people will generally tell you is you fill in the anterior 2/3 of the vertebral body, and you shouldn't fill in the posterior third. That is not correct. You can fill all the way back, top to bottom, left to right, front to back, but just whenever it starts to extravasate, just take a shot AP, just make sure we're doing okay. Stop, and when it starts to extravasate, you can put the balloon back up, blow the balloon up. You can leave it for 30 seconds to a minute. What that does is it thins the cement out and makes it harden faster, of course, at body temperature. And when it hardens at body temperature, it becomes a nice shot. Let's go back lateral, please.
Doug, when you're set up in your fluoro suite, do you have biplanar
I
for
don't.
us?
I
So-
have exactly what is here.
So you swing up and down and up and down.
I have exactly what's here, like all of this great stuff here. No, I don't have that at all. I have just a single C-arm, and we have some of the vascular rooms that we have are very nice, and some have biplanar, but I just use a regular C-arm. I have a Zeem, set of Zeem C-arms in one place, Siemens in the other, and just guard right equipped, Neil. I wish I had biplanar for everything.
The reason for
Make
that
things much
is
easier.
each of the C-arms is $150,000. So from a practical perspective, swinging up and down is what many sites do. Many ambulatory facilities are single C-arm.
But they got the Korean ones going.
That's you can go cheap,
So
but you have maintenance problems.
we have a nice fill here, and that's right in the center of the vertebral body, end plate to end plate, and that meets our goal. So we'll save that one, and we will take another shot. AP.
And Doug, on the AP, is your
And good.
goal to get support
So-
from
And, if we're dissatisfied with this, probably, given the time, I would go back and access that other side and put more cement just to make it symmetric.
Is your goal to try to get support under both pedicles?
Absolutely. So here, we're out of cement, and I won't do this because of the demonstration, but ideally what we do is we access the other side. So you just come over and commonly what I do is I'll do this, and then if I need cement on the other side, I do a quick access on the other side and just add more cement. So we'll show you. So this is a transvascular approach on the other side at the 2 o'clock position. It's kind of the polar mirror image of the approach that I just performed.
So approaching from the lateral border of the pedicle on AP to the medial border of the pedicle on AP. The length of the pedicle is the thickness of your finger.
All right,
So if you
and
just
same
put
thing
your
here.
finger
This is going to be a nice
on the
approach
jam
before
sheety
we
and take a purple pen
violate the
and mark
medial wall. The pedicle will
with
look
your
lateral.
finger. When that mark
We should
gets
be
to
in
the
a
skin,
really good
you have
position
traversed the pedicle
Approaching
can do
or
this
inside
entirely on
posterior
AP.
wall.
And that's how the
vertebra.
pedicle screw surgeons do it. They just use the AP. And the pedicle is the width of your finger. And you just mark the jam sheety when you're docked on the lateral border of the pedicle. Squeeze the jam sheety with your finger, put a purple mark on it, and then watch that mark march down to the skin as you're traversing the pedicle. And the tip will be at the vertebral body at the posterior longitudinal ligament level when the skin mark, when the mark on the jam sheety reaches the skin, because you're just tapping your way down. And that saves you from swinging back to lateral, back to lateral, until you get really facile with that, go back and forth. But mark the jam sheety with the width of your finger, and then advance from the lateral border of the pedicle to the medial border pedicle on AP. When the skin mark, when the mark reaches the skin, check the lateral, you'll see you're right on target. And after 10, 20 cases, you won't check the lateral anymore. Because you'll
So
know.
I'm just evacuating the rest of the
you're
needle
exactly where you want to
Through
be.
that, it's very thick and nice, excellent, back around AP. And so, final step here, and this is critically important, make sure you put the cannulas, fill the cannulas with the stylet. Place the stylet back in before you remove. And so now I'm satisfied.
And Doug, you're doing that because you don't want the cement to back up the cannula?
Exactly. So we put the stylet back in, we tap it down, and you make sure when you tap it down that there's no cement backing up. And you can even put a filling device and put it in and tap it, and it will make a clicking sound, a click when the cement is hard. So you don't want the cement to back up on you, so you take the internal components out, put the stylet back, is if the cement is liquid enough, it will back up on you and it will leave a tail. And that's not necessarily the worst thing in the world, but it does make it look funny. So you want to avoid that. So we're pretty happy with this. So
You have this smoke.
next thing what I want to do is show you an implant. So we will do, let's see, let's do the level above that. Okay, cool. I will reuse the same.
You've got really good fill on both the AP and lateral.
I'll use that. Yeah, I really like that end plate to end plate, and it's right in the center, and that is enough to support this with any specific additional difficulty that we have. We're gonna come a little coddle, please.
He's pointing right
UL
at
too. How
the
about that?
vertebral body artery.
Bit more.
That's right where he was pointing.
And with the Kiva approach, this is
You want to see that
that's
in your mind when you're looking at these views.
This is kind of a different approach. This is more of a transpedicular approach, and this is a very flat approach. This will go from top to bottom, is how this implant is deployed. It's deployed over nickel titanium, a nitinol wire. And so we have a left pedicle. And one of these things that you have to be familiar with, this is a different animal. So the Kiva device comes, we're accessing the left pedicle. And so it comes with either a left or right. So this has an L on it. This is the left pedicle. And we're accessing the left because this will go from top to bottom. And it's different direction on the opposite side. So these are made to go to a specific side. So on this approach, this will be fairly similar to a transpedicular approach, but just a touch more flat rather than the top to bottom kind of approach that we saw previously. All right. All right. So before we violate the medial wall of the pedicle, let's check, make sure we're in the posterior portion of the vertebral body.
So if he had marked that with the thickness of his finger, put a mark on the top, and then drive it down to the skin, he should be at the posterior longitudinal ligament level now that he's at the median.
So we're a little short. What I'm going to do is I'm going to pull this back. Let's come back AP and let's have a trajectory lesson. So this is the single pencil point, the tri-bevel needle. So I'm going to switch this out and use
the pedicle is flaring toward us,
the single bevel.
So
that allows a little bit
you
more
have a greater margin of
capability.
safety if the tip of the needle is under the ring on the AP. You know the bone is flaring
And,
away from it.
Go a little bit more lateral until we get down to the appropriate depth.
Maybe put a track to it. Does the needle tend to follow it each time?
Yes, but remember it's osteoporotic, so it's very easy for the jam sheety to act like a straw in a milkshake. It'll wiggle on you. And Doug had commented about causing pedicle fracture with an intrapedicular approach, a transpedicular approach, as you gear shift the jam sheety. So you want to be mindful that in the osteoporotic bone, you can literally move this with almost the force of your breath.
Neil's giving good tips. I can hear him. And so this is a good flat approach. We want to go lateral. I change the trajectory with the single bevel needle to make it a little bit more steep approach. And what we'll see here is we'll very likely be in the posterior border, past the posterior border of the vertebral body. So we are. So we're going to back this up right about there. I'm going to back it up just a hair more. And I'm going to change the trajectory a little bit. I'm going to go just a tad more medial. You can see from the trajectory change I'm putting on the needle. And we'll stop right there. All right, so we'll change it out with the K-wire, Kirsten wire. And I'm going to place this all the way just a little bit more. Okay,
The K-wire will
and
want
this
to
is the
back out.
rotating drilling dilator.
Not a cannula over it.
This is fluted on the ends,
Anchoring
so this helps cut bone a little bit. This can be
helps
rotated,
capture the tip.
and it will help
Pull it out.
cut bone as we drill it in.
And
So we'll go in and we can
Now you gotta start all over.
use a combination of mallet taps and twists for this.
Now, notice what lives
And
right here.
as you see, you have to make sure the K-wire doesn't advance on you. In fact, most of the time it will,
Notice what the
come
K-wire
back.
will want to
and
do.
if it gets stuck in there, just take
Any bone gets
your
caught in
clamp, hemostat,
the inner
coker,
It'll pinch the K-wire and push it with
and pull back on it until you get
You'll push
the
it
right trajectory,
right
the
into
drilling
this.
dilator. And we're going to take the drilling dilator pretty far forward. Take the drilling dilator up to about within 5 millimeters of the anterior vertebral body. And this thing will come out the center, and what we'll see is we'll be left over with the outer cannula that's quite a bit shorter than the inner portion. And I'm going to extract that. That's got a little torque on it, so I'm going to use a clamp. I'm just going to work at it till it comes out. Sometimes these will, in hard bone or a frozen cadaver like we have here, these will be somewhat difficult to get apart. Do you have a coker or Kelly? Never mind, I got it. So internal part, so I want you to look at that, focus on the lateral. I'm gonna repeat this, and there. So the interstylet on this was quite a bit longer, and we left just 5 millimeters inside the vertebral body, 5 millimeters from the distal tip. And the Kiva device, the coil goes forward with the blue knob. The implant goes forward with the other one. And once the implant is deployed, it doesn't come back. So we'll have to deploy the implant over the coil, the nitinol nickel titanium coil. So we'll put this down in, and this directionally goes to the opposite side, aims toward the opposite side. So we have a nice placement here, and this mimics the position that the interstylet was, so about 5 millimeters from the anterior portion.
Before you deploy, Doug, can you get an AP
Oh, yeah.
so that they can
Yeah, no, that's-
understand trajectory and
Come back, AP. So we can see from here, we're ipsilateral, and the coil will deploy toward the contralateral portion. And the nitinol coil is deployed first, followed by the implant. So one of these things, sticks up a little bit, but we can tell from the trajectory it goes toward the center of the vertebral body. So what we'll deploy, I'll start the deployment on the AP view. All right. And it has a certain amount of declination built in.
this implant is in the inner wall
So let's see how we do here with the deployment.
part of the vertebral body.
So we're getting a little ipsilateral. At this point in time, I may want to change and go a little bit more toward the contralateral side. So what I'm going to do is I'm going to pull this back in. So looks like we're in pretty good position, but this is a big vertebral body. And I'd rather get this more toward the center of the vertebral body. So what I'm going to do, I'm going to pause right here, and I'm going to put this back in. I'm going to undeploy this, and I'm going to take it out. So put this back in. So go ahead and swing back lateral if you would. I'll take that K-wire back.
So what he's noticing is that the trajectory is more vertical than he wants, and he wants to angle a little bit more so he deploys toward the center, because this trajectory is approaching the lateral wall of the bone.
And I'm going to go for my unidirectional needle once again. I'll put this back in. Make sure we're back into the posterior portion of the vertebral body. I'm going to remove the K-wire, put the unidirectional bevel back in.
He will back
I'm going to
up
pull it back to
base
the
of
posterior
pedicle,
portion of the vertebral body.
and he'll increase the angle. So he's aimed more toward the center. He's backing up toward the base of the pedicle. He's now
Back to the posterior wall.
Turn the bevel so that it skives you to
And I'm going to put this
center.
needle tip more medial.
Angle it more medially, and you'll end up in the center of the vertebral
And what
body.
I'm going to do, instead of going out with the K-wire, I'm going out with the needle itself, because this is what gets more directional correction by far than just going directly with the wire. So I like that a lot. And what we're going to do at this point in time is I'm going to go back directly AP and check the medial lateral position. The old saying, the enemy of good is better, is only said by people who can't do better. So you can do better. Good. So this is the kind of area where exactly, if you can imagine the coil starting in this position going medially, that's exactly where we want to be. So we'll change it out.
What's the risk of Binocular fracture with that much manipulation?
So in this type of bow, yeah.
Let's go lateral, please.
And
We'll do
yes,
this work on the lateral usage to do the change outs and to make sure we don't lose access.
easily and
Like that much movement would be-
accommodates that much movement.
What happens to the pedicle after?
Fills it.
It fills it by itself?
Yeah, same process occurs when orthopedic surgeons remove screws from
So back to fluid dilator.
period of time. From outside in, it closes in.
This, of course, has a hole for the K-wire in it. Okay. And
During that 6-week period of time, you can refracture through a plate hole, a screw hole, through a jam sheet. But routinely, with the cement augmentation, the bone is now so strong, the pedicle is secondarily protected.
all right, we'll get that up right there. And now you can see the trajectory is a little bit more favorable than what we have had it. So again, we'll pull this apart. And this time, of course, it's easier. And we'll redeploy the left key device. And as a nod to Dr. Schonard, we are going to check the medial lateral view. So we're coming back AP, which we would do absolutely anyway to make sure before deployment of this, the coil, nitinol coil, that we're in the center of the vertebral body between the pedicles. Technically, as long as you're between the pedicles, it doesn't matter whether you're dead center or 5 to 7 millimeters to either side of dead center. It just matters that you're between the pedicles, because that's where the biomechanical support primarily occurs. Okay,
And that's
so we're going to deploy this,
spine surgeons use this criteria.
starting off with the coil.
In the front of the spine and the disc space.
There.
Expand between the pedicles.
So, a little bit more toward the center of the vertebral body, kind of like this. Yeah, we're a little bit toward one side, but that's just how it's gonna be. A little bit of wire buckling and this frozen cadaver. So what I'm gonna do is I'm gonna turn it back, and I'm gonna work this in conjunction with the implant. So let's go back lateral. And what we're going to do is we're going to put some of the coil out, and we're going to put some of the implant out, and we're going to use the implant to bolster the strength of the coil, and we will do it like that. And so have the coil, this is kind of nicely deployed, and we're starting to get a little buckling. So I'm going to put this, bring it back. As I mentioned, once the implant goes out, it doesn't come back. So I'll deploy it with pressing the orange button. As the implant goes out, you'll start to see it is a peak, so it's radiolucent, but it has a radiopaque distal tip. All right. All right, so we have a pretty frozen cadaver, and that's maybe about as much of a deployment as we're going to get out of this. Let's see. Let's check at AP, please. And if we do, that's no problem. What we'll do is we'll turn the coil back in, and the peak device is designed to be completely deployed, and it has little notches in it. So if you can just get a coil or two in, a sufficient amount is about that. One coil is sufficient to make a biomechanical difference. And so we will advance this out as much as we can, and I will pull the coil back. Let's see, get some implant out, pull the coil back.
And once the cement is hardened,
And it has an indicator that I'm watching. So whenever the coil goes all the way back inside the housing, you can tell it's inside.
So that's a separate course.
And we'll save that. And that is the implant's marker, that little tantalum radiopaque marker. Okay. Make sure everything's inside. We'll deploy the lever, move this, pull up on it. And for the cement distribution, we have this breakable tube that has a part that has cranial on it. So we could demonstrate that this is toward the outer portion. This goes down, and we'll have a device that once we hit the distal tip, will break off. As this is, it depends on how much you put in terms of the length of the coil. The longer the coil, the less of this you break off. And then we'll mix the cement, and we'll put it down through a small tube, and there's a small tube that fits into the end of this and through into the peak implant itself. And then when the injection happens, it will happen inside the coil. The coil has a centripetal type injection. It injects from the outer portions in, and this is ideally suited for things that are lytic metastatic lesions. It's ideally suited for people that have problems with cement extravasation. Typically in the cast trial, we had less cement extravasation and less cement overall administration. So this was something this device has a little flexible tip on it, and it's got a little cement, so we'll pull that off. And this tip, the flexible tip, is designed to fit down inside the coil. So it's designed to test of your presbyopia to see if you can actually do that, fit it on there. Okay, so fit pretty nicely. We will see some of the cement coming out already, and of course we're going to fill the cement on the lateral, so let's take a look lateral. The difference between this and some of the other techniques is the cement for this is very liquid. It's shiny whenever you first pass it through the needle and through the needle cement delivery device, and it's designed to have more of a liquid cement delivery than the much more toothpaste and thick toothpaste-like delivery consistency of the previous case. So coil in place, cement going in. Turning is very easy because it is very liquid cement. And you can see it's kind of a tubular shape. It's designed to inject from outside to in. And because of the presence of the coil, you don't need as much cement. The difference between this and something else, another technique involving balloons or this garden variety straight vertebral plasty, is you don't need as much cement because the implant is space occupying. Okay, with that, I'd like to get a shot AP and see how we're doing. So the presence of the implant itself was one of the reasons why the cement amount was less, because it takes up about 2.4 milliliters of cement. Displacement is about what the implant would account for. Good.
Doug,
So,
same parameters for judgment, end plate, pedicle to pedicle?
yeah. You know, the advantage of the implant is when you put some loops or you put an implant in the vertebral body, it helps support it. So the distribution of cement we find is not quite as important with the implants as it is with just regular balloon kyphoplasty, because, you know, in this and the cast trial, it turned out it wasn't nearly as important to have as much cement to get the same results as it was compared directly to balloon kyphoplasty. There's quite a bit less cement, but it provided non-inferiority trial. It was a non-inferiority trial, but it provided as much support. It had almost significant less adjacent level fractures. It had significantly less adverse events, and overall it was every bit as good as balloon kyphoplasty. So there we go. I mean, that's it for the Kiva device. Performed very well, even in a very hard internal cadaver. That was hard enough so where you can see the nitinol wire that's very sharp and pretty sturdy. Had a difficult time deploying even the nitinol in that, but despite that, we got a good result. And after you're finished, and after the cement hardens, you take the needle, you turn it this direction, and you turn it the other direction, and you can pull it directly out. And what it does is it takes the implant and it shears the implant. It's designed to break. So when it goes in and pulls back, it has a great resistance to force, but when it twists, it can break, and it's designed to do that. And the rest of the implant is broken off right there, and the final shot, final implant is right there, and we're pretty happy about that. Right, Jason?
Those x-rays look great. Doug, would you agree that for a balloon kyphoplasty, either bipedicular or unipedicular, a lumbar or lower thoracic vertebral body would benefit from 6 cc's of cement as
Yeah,
an approximate volume, and this might take less?
Yeah, that's right. So if you have roughly 2.5 cc's of cement space occupied by implant, you can put less cement in. The real important point is there's enough support, top to bottom, left to right, inside the vertebral body to function as an intervertebral strut. I mean, what you want to do is have this vertebral body be able to support force over time, have it not break down. If I were to say one of the errors that people make is not putting enough material in, whether it be implant or cement. If you're using implants, that's fine. Put implant plus cement. If you're using just cements and balloons, put enough cement. So on the average, the Swiss registry says we use 5.5 cc's of cement or more gives you better results. I mean, this will be the single modifiable thing that you can do that will give you better results in terms of greater pain relief and greater duration of pain relief. And one of the things I see of most common errors, given the fact that this is a single modifiable thing that you do that will make a difference in duration and amount of pain relief, the most common error that I see people make is not enough cement. And they're afraid of extravasation. So sharpen your eye, look for extravasation. Extravasation into the canal matters. Don't do it. Go back in and blow your balloon up, or wait. Go back on the other side. Wait till it hardens, and it will automatically plug. Harden it at a faster rate inside the body than it does on the back table. And you can go back on the other side. You can go back and add more cement, or you can go back through the same needle after having used your balloon to reinflate using the eggshell technique, thinning the cement out, causing it to harden and plug the leak, and go back and fire away with some more cement. So just extravasation laterally doesn't matter. Extravasation intravascularly won't matter if you unless you keep injecting. And then it goes to the lungs, and it can matter greatly. It usually doesn't, because pulmonary emboli, people say, oh, that's terrible. Happens between 5 and 23% of the time. Just does. So just don't get the amount of cement. And if it extravasates posteriorly into the canal, that's a very important thing. Stop. The basivertebral plexus has a membrane over it, and it's lenticular in shape, kind of crescentic. And if you keep injecting, that will go up and down the canal and can compromise the cauda equina, spinal cord, the conus medullaris. But if you stop, it will plug itself, and that's the safety mechanism designed It's the membrane covering the basivertebral plexus will protect you to a certain degree, but the recognition of the cement extravasation and the recognition of it going posteriorly or into the canal around the neural foramina is exceedingly important. But again, extravasation around the paraspinal region and even into the disc is usually incidental. The Beall trial, we had 21.4% extravasation rate. The amount of symptomatic extravasation rate was 0. So just as, and the vast majority of it, 80%, went paraspinal and into the disc.